We're going to finish up talking about congenital heart disease today, talking about common AV canal defects. So you see, this is more complicated than we're going to talk about because there are more presentations of common AV canal defect that you will learn about in pediatric echo in your last semester. That's going to be true of probably a number of things we'll talk about today. You'll get more information because there's more stuff that shows up in newborns than in adults. But if you come across an adult with a common AV canal defect, they will likely have one of these presentations, probably incomplete. You can see with, let's look first at the terminology. So we could call it an AV canal defect or an endocardial cushion defect because the valves develop from the endocardial cushions, in these regions right here, which I think you learned from Dr. Baisha in anatomy. Did you have a lecture on that? Also, they can be called atrioventricular septal defects. So with a complete AV canal defect, there's a VSD, so that's a big difference. And you see that there is a common atrioventricular valve. So it looks like one annulus here. And you don't see septa in here in this region where there's a big defect. Now there's the ostium primum ASD that is common to both of these presentations of the AV canal defect. And the difference here with the incomplete or partial AV canal defect is that you're seeing separate atrioventricular orifices. And we expect to see a cleft mitral valve. So let's see what that looks like. So I don't have a video of it, but it just looks like there's this indentation in the anterior mitral leaflet. You see this best from the personal short axis view. So remember that association, cleft mitral valve, ostium primum ASD. All right, so what do we have going on here? With the complete AV canal defect, a large left to right shunt with a biventricular volume overload. That's because we got the VSD. Pulmonary hypertension from the VSD, increased flow through the pulmonary circulation will create that. And usually the AV valve is dysfunctional with regurgitation. With the partial AV canal defect, again, we got the large ASD, which is ostium primum, left to right shunt, right heart getting bigger, and then the normal LV size unless the left AV valve is leaking. We mentioned this with what did we mention that with? The VSD, Down syndrome. So Down syndrome is showing up here very frequently with a common AV canal defect. So you can see that risk increased 1,000-fold in Down syndrome. So strong association with common AV canal. All right, you can see here, well, you can see it best on the right that there is a VSD. So when you see that VSD here with the ostium primum, you're thinking, okay, that's the complete AV canal defect. So this was in an adult at West Jeff years ago that I got this video. You can see that's a TEE. I probably stole this from an ASD guideline. So can we, whoops, we want to do that. Play. All right, so we can see, you can't see the interatrial septum very well at all here, but you can see it's hard to tell if that's VSD. It looks really thin right in there. Just looking at that, to me, that looks like not complete. It looks more like partial, but this, I'm sure I got it. They said it was complete from where I got it from. Yeah, I can't really see any interatrials. It does not look like it looks like they're looking at it from because they got the transducer down here. That's a typical pediatric presentation. I don't know if that video is helping us at all. I should probably just throw that one out. The other one will look better, less confusing. All right, PDA. So this is going to be more common in adults. You see, it's common in preterm infants and tend to close up. Sometimes we do not want them to close up. So the drug that I couldn't remember the name of last week is indomethacin. That was what they would give if they want to keep the ductus open. And so we're going to see a condition or two later on where we want to keep the ductus open to help with oxygenation. But normally we want them to close. So patent ductus arteriosus connects the main pulmonary artery with the descending aorta. You remember what it's called when it closes up that you saw in the cadavers?
Closes up effectively.
Yeah, and then what the residual ductus is called. Ligamentum arteriosum. Remember that one? All right, here's our pathophysiology. So where's our ductus? Find it right there. So you have to remember aorta to pulmonary artery. So aorta high pressure, pulmonary artery low pressure. Normally, that's what we expect. So that's going to create a shunt. So it's typically a left to right shunt. It may be right to left or bidirectional. It's my wife calling, but it's usually a bad sign when my wife's calling. That's a long story, but at least these days it's a bad sign, but not always. Okay. Increase in pulmonary vascular resistance. So why is that happening? We got lots of flow going through the pulmonary circulation. That's causing remodeling of the pulmonary circulation and over time, increasing the pulmonary vascular resistance. So that creates pulmonary hypertension, which may switch the shunt to a right to left, maybe just during parts of the cardiac cycle. So that would make it bidirectional. So when it switches from left to right to left, what do we call that? Remember from last week? What's that? Paradox. I don't know of any paradoxical shunt term. I heard of paradoxical embolism. Eisenmenger syndrome. I'm sure you'll know that by the time you take your test next week. Next week, the year before you know it. Next week, what? A week early. Yes. All right. If the shunt's reversing, you get cyanosis. Now you've got deoxygenated blood mixing in with the oxygenated blood. All right, so here's a question they like to ask on registry exams. We get a continuous murmur. I believe we already saw a condition from last week where we had a continuous murmur with the, was that last week? I know we saw it with the ruptured sinus valva aneurysm. If we hadn't seen it last week, we're going to see it this week coming up. So we'll get there. So, the condition for this is we just need a pressure difference maintained throughout the cardiac cycle where the left-sided pressure higher than right-sided pressure, allowing the flow to continue throughout the cardiac cycle. Widened pulse pressure. Oh, this is physiology, your favorite subject. What's happening here? So what's the pulse pressure? Forgot. All right, so I asked that question to the seniors and none of them remembered what it was. So remember, a year from now, what pulse pressure is. Don't forget it. Systolic minus diastolic. All right, so you got to think about what's happening to those two pressures as blood is going from aorta into the pulmonary artery. So now we have blood going forward in systemic circulation, but also going into the pulmonary artery. So blood can leave the aorta two mechanisms. Which means the diastolic pressure will do what? What's that? Drop more than normal, because that's the way that the arterial diastolic pressure falls, is because blood leaves. Now it's leaving through two sources. So you get a similar effect with bad aortic regurgitation because blood's going backwards out of the vein. But in this situation, it's just going through the pulmonary artery and forward in the aorta. So that makes the diastolic pressure fall more. Okay, systolic pressure, I got extra blood flow going through the pulmonary circulation and coming into the left side of the heart. So that's going to mean a bigger stroke volume, which will give you a larger systolic pressure.
So a larger stroke volume with less cardiac output.
Less cardiac output, let's see, no, I wouldn't necessarily say less cardiac output.
So cardiac output stops kind of once it passes.
It would depend upon the size, probably the size of the PDA as to if we say how much is getting out to the tissues. Yeah, it's a big stroke volume, across that aortic valve. And then if it's a bad enough PDA, yeah, it's not enough getting out to tissues, which we ultimately cardiac output. So it depends on how you measure cardiac output. If you just measured it by heart rate times stroke volume across the aortic valve, you're not going to see it, but because it's getting pumped, it just ultimately then goes distal.
Functional.
Distal, yes. In terms of what gets out to the tissues, yeah, that could be reduced. All right, what do we expect to see? LV dilation and hyperkinesis, because this is a volume overload for the left side of the heart because of the increased flow through the pulmonary circulation coming into the left atrium and left ventricle, which means the left side is going to dilate. The hyperkinesis would be a response of the ventricle to the volume overload, so we hope to see a hyperkinesis. That would be Starling's law of the heart, increased filling of the ventricle. It therefore will pump more strongly because we're stretching out those muscles. Pulmonary artery is dilated because of increased blood flow going into the pulmonary artery. Evidence of pulmonary hypertension. Oh, I forgot. What's our evidence of pulmonary hypertension?
Wait, what did you forget?
Evidence of pulmonary hypertension. What is, how do you know? You're just copying what's on there.
Is it increased?
That's not, dilated left atrium is not specific at all. So we want something that's more specific to pulmonary hypertension. Right, look at it and say, oh yeah, I think there's probably pulmonary hypertension. Left atrium could be, okay, they got mitral regurgitation, they got mitral stenosis, they got diastolic dysfunction, but that doesn't necessarily mean there's pulmonary hypertension.
Maybe right.
Not specific. RV hypertrophy. That's relatively specific. Not absolutely specific, but probably good sign of it. All right, what else? All right, what are you gonna do with that tricuspid? Just because you have tricuspid regurg, yeah, that is, you normally have tricuspid regurg, right? A little bit.
Reversal.
Sure what that means. Be more specific.
Adding fluid reversal or.
That's referring to the severity of the tricuspid regurg. All right, so if you got significant tricuspid regurg, then pulmonary hypertension is the most common cause of that. But what are you gonna do? What are you gonna do to help indicate there is pulmonary hypertension? The sonographer. You see the tricuspid regurg, what do you do?
Pulmonary artery pressure.
All right, and what are you doing to get that? What about?
Measure.
You're measuring the IVC. Why are you doing that?
More than 2.1.
More than 2.1.
It's needed, I know. Right heart.
All right, so this is helping you determine the,
Uh,
well, that's part of it, and it's helping you determine what?
right.
The right atrial pressure. What are you doing with that right atrial pressure? With that knowledge?
Wait, ask that question.
What are you doing with the knowledge of the right atrial pressure? Why do you care about that?
Systemic medicine. You call it right?
What?
If you have right, you just said increase right.
Increased right atrial pressure. What am I doing with that information?
Figure out what's the articulation.
Figure out the pulmonary artery pressure. Specifically, the RV systolic pressure, which you are assuming to be equal to the pulmonary artery pressure, unless the patient has of what? Pulmonary stenosis. And the two are not going to be the same. All right, so what we're doing is we're estimating the pulmonary artery pressure, which would tell us if the patient has pulmonary artery.
I'll say it one more time.
Which we covered way back in hemodynamics, and it happens on every patient you have. You measure the peak velocity of TR, right? That's why we're doing it, see if they have pulmonary hypertension. Don't act like it's a surprise. It shouldn't be a surprise.
So this was our problems we did on the board, right?
Yes, as one of them. Now, that's helping you, that's evidence, doesn't guarantee because it's not foolproof. Other evidence, we mentioned the RV hypertrophy, but what you don't want to forget is the flattening the interventricular septum. There's a high pressure switch in the septum. That should be the first thing in your head. This high pressure shoves the septum move. Your brain should go boom right to that. Okay, maximally flattened septum at end systole. That would be pure pressure over. Maximally flattened septum at end systole. All right, so we got a PDA, we want to close it. What are they gonna do that? They're gonna put in a coil, close it with a catheter. That's transcatheter closure. So you got to measure the length and diameter of the ductus. So you got to be able to see it. Not always that easy. Frequently not easy. Now, what you can see, and we'll show a video in a second, what's easier to see is just identify that there is a PDA by looking at the flow. So this is the systolic flow, which is pulsatile. Then you got this flow, which is happening continuously. It's kind of like right next to it. And now this is what you see on spectral Doppler. It's continuous. Now you might get a little bit higher velocity during systole than in diastole, but it's there the whole time. This is what you see. See how the blue is pulsing? But this is happening all the time through the duct. So you see that, boom, your brain should go immediately to PDA. Yep, that's turbulent flow throughout the cardiac cycle. So it looks like it's starting right there. From the descending aorta to the pulmonary artery. All right, next defect, partial anomalous pulmonary venous return. So this is different from total anomalous pulmonary venous return, which you will not see in adults because they would be dead, but they would be fixed. Okay. They gotta fix it right away. But not partial anomalous pulmonary venous return. That doesn't have to be fixed right away. That's gonna cause some problems. All right, so there's several different presentations. We could have right pulmonary veins to the superior vena cava. Okay. Could have right pulmonary veins to the inferior vena cava. Left pulmonary veins to the left brachiocephalic vein appear via the ascending vertical vein, which is right here. So LPV, left pulmonary veins, vertical vein. So this is it says left innominate vein, another word for brachiocephalic, coming into the SVC. So you see it's all coming into the right side of the heart. Then we have left pulmonary veins to the coronary sinus. There. Again, you're thinking extra blood flow, extra blood volume to the right side of the heart.
Was that suggesting that it runs posteriorly to the heart?
It does suggest that. All right. Pulmonic flow murmur, that means increased flow across pulmonic valve. So that you could hear that. There's some turbulent flow as a murmur. RV volume overload. How do we know if there's an RV volume overload? What's that going to look like on the echo? Large what? Large what? Large right ventricle. Right ventricle is getting bigger. Okay. And what's happening to the septum? Pushing over during. Don't say systole. If you say systole, it means you're not thinking. Right? Because what's happening in systole, the LV pressure is high, pushes the septum back over. But in diastole, because all this blood's coming in, higher diastolic pressures pushes the septum over. So that's your signs for volume overload. Diastolic, in diastole, maximal flattening of the septum, meaning pushed over towards the left. But then during systole, higher pressure on the left push the septum back over, and that's called paradoxical septal motion. Yeah, so once you get that into your brain, it shouldn't leave your brain. You're just thinking, when's pressure high? What makes the pressure higher with this? Because they have volume overload. Same thing we saw with an ASD. Extra flow coming in the right ventricle, pushes up and over. During systole, pushes up and back. Simple. Right? So that way you get that in your head. You don't have to memorize stuff. So as I continue to tell the seniors, don't memorize if you don't have to. Makes echo a lot easier. Start with the pathophysiology. Understand why you see the echo signs you see, and life gets a lot easier. But if you just look at a bunch of words on the slide and say, I gotta memorize this stuff at the top, you're dead. You're not really dead. Long-term does not help. And you want ways to remember for a registry exam and for a life in general. It's just a bunch of words will mean zero. We all know we can memorize a bunch of words for a test. You don't want that. You want long-term memory. All right. What else is significant here? If you got a sinus venosus ASD present, your brain should instantly go to, oh, that connects to partial anomalous pulmonary venous return, because the sinus venosus defect is close to those pulmonary veins. So you can put that association in your brain. All right, well, how did we see the sinus venosus ASD? Well, maybe color showed it. And then we could confirm with what? What's you using to confirm the presence of the ASD? What? Well, we had the color, and we think it's there, but sometimes fools you a little bit. And that's bubble study. Bubble study confirms the presence of the ASD. Possibly needing a blank in association with the bubble study to help see the shunt. What's that? Valsalva, which it's during the release of the Valsalva maneuver that the shunt occurred. All right, right heart enlargement without an ASD would be a clue, because when you see right heart enlargement, ASD should be one of the first things in your head. Then you realize, oh, there's no ASD, then what else could it be? So when we go through the echo interpretation class, we're going to put all these things in our brain in our differential as to what it could be, what could cause right heart enlargement. All right, inspect the pulmonary venous entry to the left atrium. Apical forechamber is where we're used to seeing the pulmonary veins, but we can also potentially see them in the parasternal short axis view. right? Level of the aorta, left atrium's right there. We don't normally look for those things, but they are there. So costal view is the left atrium, and then suprasternal, there's a crab view. You're gonna learn about that in pediatric echo, where you can see the pulmonary veins coming in. It looks kind of like a crab, 4 veins coming into the body of the left atrium. You'll see that later on in pediatric echo. Easier to see in kids than adults, but. All right, the next abnormality, persistent left superior vena cava. So normally the left superior vena cava goes away, but in this case it doesn't. And it connects to the coronary sinus. So it makes the coronary sinus big. So this is probably the most common cause of a dilated coronary sinus. They like to put this on registry exams, but it's unusual. A dilated coronary sinus is kind of cool looking. All right, I added this to the PowerPoint. You don't have it, so put it in there. Because I was wondering to myself, I said, self, what is the clinical significance of a persistent left superior vena cava? So I had to look that up on Google. I don't know why I didn't ask myself that previously, but I did this one. And it says may cause arrhythmias and cyanosis. Why? Because all this blood coming into the coronary sinus empties into the right atrium, could make the right atrium a little big. If you make the right atrium a little big, that could make arrhythmias. Anytime you stretch the muscle in the atrium, you're asking for some trouble. Cyanosis, because now the right atrial pressure could be going up with all this flow in there. If there is a PFO, that's what that's kind of suggesting here. See that it's not really closed up very well. So you could, if you have a PFO, you can get in high right atrial pressure and then boop, right to left shunt, cyanosis. So a lot of the time, though, no clinical presentation. All right,
So
so
that because you so much more often have such a high left atrial pressure that you just don't.
yeah, I'd say yeah. All right. There's the coronary sinus. It is not a coronary artery. Do not be fooled. There's coronary sinus right there in the groove, the atrioventricular sulcus. It looks big. Now, if you want to see it in the apical 4-chamber view, you tilt the transducer posteriorly. It looks kind of big opening into the right atrium there. And what you're going to do to confirm this connection is do a bubble study, agitated saline injected into a left arm vein, because then it's going to go drain via that left, the persistent left superior vena cava. Okay, that's a question they're going to ask you on a registry. Left arm vein, not the right arm vein, that'll be the left arm vein. Make a note of that one. Okay, and then the bubbles will show up in the coronary sinus and then into the right atrium. So they could show you a video on the registry exam that show you those bubbles going into a dilated coronary sinus, and boom, your brain should go automatically to persistent left superior vena cava. And they could show you the peristernal long axis view, and you see the bubbles show up right there first, and then up there in the right ventricle. If they inject agitated saline into a left arm vein, and you're looking in the peristernal long axis view, you'll see the bubbles show up in this dilated coronary sinus first. And then they'll show up in the right ventricle. It's going to be like very soon after, but first coronary sinus. All right, here's our next continuous murmur, the coronary fistula. Connection between coronary artery and a cardiac chamber, great vessel or something else. So most of them you see terminating in the right heart, creating a continuous murmur because you got a big pressure difference. Because the coronary artery is coming right off the aorta, it has high pressure. And then it empties into right atrium or right ventricle pulmonary artery, that's lower pressure, so you get flow continuously going from the coronary artery into this other structure. All right, you might get RV volume overload because of that extra blood flow going into the right side. Proximal coronary artery enlarge. Ooh, where else do we see an enlarged proximal coronary artery? Two conditions that we've talked about. In your brain yet? No. Kawasaki disease, that was the aneurysmal proximal coronary artery. In supravalvular aortic stenosis, because we have a narrowing distal to the coronary arteries with pressure backs up and. All right, so color Doppler will help us localize this exit site. And if it's a big fistula, you gotta close them. All right, now we're getting into complicated stuff. Because the stuff we talked about so far is super easy compared to this stuff. Aren't you excited? I can see it all over your face. Tetralogy of Fallot, have you heard of this? Cousin Vinny? Your cousin Vinny?
No, she's 4 years old, Down syndrome, autistic.
Oh, wow. Tough start to life.
She's the happiest baby I've ever been around, but other than that, yeah, rough.
All right, you've heard of Tetralogy of Fallot. Dr. Casey talked about Tetralogy of Fallot.
Yeah, just,
Just a little, so you're experts on this, so you can just skip over it, you already have it. All right, so, most of the time, this is, you're not gonna see this in an adult. Okay, but sometimes, it's not too terrible. Because there are varying degrees of these abnormalities. And you'll get much more on this in the pediatric echo class, but just in case, this might show up on a registry exam. So what's the problem? We got malalignment of the infundibular septum. So it's creating this VSD. You see it's anterior malalignment of the infundibular septum or hypoplasia of the subpulmonary infundibulum. Remember what the infundibulum is the right ventricular outflow tract. So this creates a large overriding aorta. So the aorta like overrides up onto the septum. So that's your main problems. This creates some RVOT obstruction. Now, the RV hypertrophy is in response to the RVOT obstruction. So it's really only 3 things wrong with one compensation. But this guy Fallot described it as 4 things. So they call it tetralogy of Fallot. Here's a good test question. Most common cyanotic heart defect. Why is it cyanotic? Because, well, I got RVOT obstruction, which raises the right-sided pressures, which is why there's RV hypertrophy, and then I got a VSD here, so that creates right to left shunt cyanosis. And there could be a lot of other stuff going on. Right to left. All this stuff. All right. I do not anticipate that I ask any questions on this. This is just to let you know that this can be pretty darn complicated with lots of other things going wrong. This is why people either want to be pediatric sonographers or don't want to be, because it can be a big mess. All that. Wow. All right, here is our aorta overriding the septum. There's a VSD. RV hypertrophy, thick walls there. All right, so this is a short axis view. Here's our VSD. This is narrowed in here in the outflow tract. This is all pretty narrow. This pulmonic valve here, here's the narrowing just proximal to it. And
Here we see a parasternal
gonna
lung
talk to
axis
you.
view of a patient with tetralogy of Fallot.
not very loud.
Notice
You
the
can listen to her talk
aorta
to you.
is
So
straddling
this is from the ASC
ventricular
guideline
septum,
that I have on Moodle,
and there's a VSD
pointing
present.
out the VSD. Right here.
Here we see a parasternal
Keep
lung
saying it
axis
here,
view of a
see.
patient with tetralogy of Fallot.
So this is the aorta
Notice
overriding.
the aorta is straddling the ventricular septum,
Thick wall.
and there's a VSD present.
This is a nice guideline, get a chance to read it. Okay, how do we repair this? So for a long time, these kids just died. Unfortunate. Now, if there was a movie came out in 2004 called Something the Lord Made. I don't know if you had a chance to see it. It was on HBO. Back in those days, I had HBO. I had HBO a long time. So I watched this movie, and it's all about this guy, Viv Thomas. So it's all about this whole situation. See, back here in 1940s is when this repair was created. And this was initially called the Blaylock-Taussig shunt. There's Alfred Blaylock and Helen Taussig. They were the cardiologists involved. One of them was, at least one of them was a surgeon. I don't know if there was. But there was a surgical technician named Viv Thomas who got no credit because he's black. And that's why, this is why I made the movie. There's a cool story because Viv Thomas was Alfred Blaylock's technician who developed this repair in dogs. And they connected the right subclavian artery to the pulmonary artery. Now, they did not use a Gore-Tex tube back then. Later on, they put that in. They were just connecting the two. And that was allowing blood flow to go through the pulmonary circulation by making this repair. So they learned that they could do this in dogs, and then they tried it in humans, and these kids were living. So they used this repair for a long time, as into the 1990s. So you can still watch this movie. You can rent it on Hulu or a bunch of other things. So I recommend it. This one award is very good. So I think they even created a statue of Viv Thomas, and put on Johns Hopkins and stuff. Yeah, but he got his credit eventually, but it took a long time. So now in later years, they've been calling it the BTT shunt, the Blaylock-Thomas. All right, so nowadays, though, they're not doing that. They're doing a repair. Right, so they're gonna patch the VSD, and they're gonna kind of open up this RVOT, get rid of that stenosis. So it's called a transannular patch. The thing is, what that does is it makes the pulmonic valve leak like crazy. So patients have to tolerate the leaky pulmonic valve. So with echo, what you're going to do is determine the severity of the pulmonic regurgitation, assess for aneurysms in this area, see if there's any persistent obstruction. Of course, you're always going to assess LV and RV size and systolic. Now, what's interesting is that the aortic root can dilate. So I looked that up. Why does it dilate? So it could be just kind of an intrinsic abnormality in the aorta. But they also say, well, it could be because of right to left shunt. Well, I think that'd only be right to left shunt if there's some residual shunt there. If they didn't close. If you close it up, there's not going to be right to left shunt. So I would say, they also said, I was reading about a case study, they said, well, that patient had systemic hypertension, that's what contributed to it. Okay, but why they would necessarily have it linked to this, don't know. Well, it could be an intrinsic abnormality, meaning some genetic association that's causing weakness in the aorta, but the case study I was looking at, it was a huge aorta. They said that systemic hypertension was contributing to it. So just know that association that in these patients, the aorta could get big, so they would have to monitor. Chances are that's who you're gonna see, people who have repaired tetralogy. Which do I have? I can either keep going, or we can take a break, if you want how your bladders are doing. What slide am I on? 67, you wanna take a little break?
I wouldn't mind
Give your brain a little break, and then we got some stuff coming up that's a little complicated. And it helps to be sharp. Oh,
They had a head start.
good, let's see, might have to steal one for after lunch. Right heart doesn't really like that, eventually it can have problems. That didn't work, let's click on there. All right, now, speaking of complicated, are you ready? So
Really complicated, can you use the cursor? Mouse, so that we can see it on the recording.
I suppose I could. All right. So I'm only showing you D-transposition of the great arteries because we're then going to talk about L-transposition of the great arteries. You're going to see L-transposition in adults. You're not going to see D-transposition in adults as kids. But you're going to have to learn this later on for pediatric echo, so it doesn't hurt to get an introduction to it now because it's kind of, as I mentioned, complicated. So I pretty much don't want to see this on presenter view on either one. Is there a way for me to take that out? Because it looks so small on here, but and I don't have any notes or anything, but oh well, whatever. Let's get out our little pointer. All right, so this is the normal circulation here. Okay. Now notice that here's the pulmonary artery, and notice the normal orientation of the pulmonary artery versus the aorta. So they're kind of at right angles to each other. So where you could see, normally when you see the aorta on FOSS, when you see the leaflets, you don't see the leaflets of the pulmonic valve coming straight at you. They're kind of turned 90 degrees, so you see a couple of cusps. So that's normal. But when you have transposition, notice the position of the aorta and pulmonary artery. They're kind of more side by side. Okay. Now the aorta and the pulmonary artery are switched. That's the transposition. Okay. So here's your right ventricle pumping into the aorta. Okay, and then you have the left ventricle pumping into the pulmonary artery. So the right ventricle is receiving the deoxygenated blood and pumping it out to the systemic circulation. And it's coming back to the right side of the heart. That's not very good. Left ventricle, pumping it to the pulmonary circulation, and it's coming back to the left side of the heart. So now I got two circulations that are in parallel. They're not pumping to each other, they're not in series like they normally are. So that's not very helpful. Okay, we're not getting any oxygenation going to the body. So how can these people live? They have to have a connection somewhere. So in utero, we got connections, right? We got a foramen ovale. That's a connection. We got a PDA. That's a connection. And then when they're born, those connections should close. Whoops. What's that?
This, right?
Well, they may not, with the, the ductus probably staying open, And they would definitely give them indomethacin to keep the ductus open. What they used to do is they would smash, or they would, and make the hole between the two atria bigger. And they would put a balloon in there and just like yank it through, and a huge balloon to rip that thing open. Okay, it's kind of messy. So Dr. White, cardiologist, he shows video of them doing that. He gives a lecture on this in the pediatric echo class. So, of course, we need a better long-term solution for this. So this is just showing you what's going on here, just a little more explanation. You know, the aorta is getting the deoxygenated blood, so forth. So this is all, we mentioned this, you need a communication, PFO or PDA. So nothing really new on that slide. We're coming. We're getting to it. Hold on. All right, so there are some defects associated with this. So VSD, that's helpful, because that's connection. Pulmonary outflow tract obstruction can be occurring. Coarctation, we said that's narrowing of the aorta. Aortic arch hypoplasia, so it's kind of underdeveloped. And then you can have some coronary artery anomalies. All right, so here's the procedures that were developed. So Mustard and Senning, very similar. I think some of the materials are different, maybe. So what they're doing is they're creating these baffles, which are redirecting the venous return. All right, so we've got this flow coming in, you see from this superior vena cava, inferior vena cava, and they're going to redirect that with these baffles into the left ventricle, so left side of the heart. Okay, so this is deoxygenated blood. Remember, the left ventricle is pumping to the pulmonary artery. So we want to get the deoxygenated blood through the pulmonary circulation. So they're directing that flow into the left ventricle. It then pumps out into the pulmonary circulation. Okay, so they have to have another baffle that's going to direct the pulmonary venous flow over here. So this is oxygenated blood over here into the right ventricle, and it pumps out to the systemic circulation. So you can see that right here. Oxygenated blood from the lungs returns to the pulmonary veins and is diverted to the pulmonary venous, which is the right atrium over here. See, PVA is pulmonary venous atrium. Okay, so you can't really see that baffle. You see this one here, and it's hard to see the other, but there'll be another baffle coming over here. So they're kind of crossing each other. All right, so that would create for better oxygenation. All right, well, what's the problem long term here? Yeah, the right ventricle pumping to the aorta is a problem because that's high pressure. Right ventricle is not going to be a fan of that. It's going to give out eventually. Okay, so we need some other solution.
But does it not, because this is congenital, does it not kind of just develop in a way that the right ventricle?
Well, it will try. It will hypertrophy. It will look more like the left ventricle, but it's not going to, long term, it's not going to work. It's going to, give out. So this is just some images showing imaging of the baffles. So they're saying what to do with the transducer, posterior angulation, slight medial tilt, showing the SVC channel, which is where this little asterisk is right here. That's the superior vena cava channel. So this would require, if you saw this would require some telemedicine from the cardiologist or sonographers who do this all the time. Because this will be challenging stuff. So this is just showing, they're trying to look at these baffles to make sure that there's no complications with them. Here they're showing tilting, showing the IVC channel. Okay, so that's all. That would be, it's not something you would just know what to do. You can see there can be problems with these baffles. They can leak, they can become obstructed. RV dilates and poops out. Tricuspid regurgitation, because you got high pressure, it's going to make that tricuspid valve leak. So here's what they do now. All right, so they're going to take the aorta. So it's normally over here. Okay, right? It's connected to the right ventricle. So what they're going to do is they're going to cut it and move it over here. When they do that, they got to also take the coronary arteries with it, move them over there, right? Because the coronary arteries are down proximal. You're cutting up here, so that's distal to where the coronary arteries would be. Just, move the whole aorta. But then the coronary arteries have got to be transected, tied off, moved over. That sounds like quite the operation to do that. Okay, and you switch the pulmonary artery. Okay, you got to cut that off and move that over. Okay, so you can see that we've now just, this is called arterial switch operation because we're just switching them. Switching the great arteries and the coronary arteries.
Why would you say that wasn't the first?
Probably because it's really difficult.
Just
Transecting coronary arteries and reattaching sounds like a nightmare.
they're that small? Or
They're not very big. So I think it's just something that wasn't, that either they didn't think it up or I don't know. Just thought it was too difficult, but
seems a lot of cutting.
yeah, you're right. There's probably a better answer. I have to read the history of it, which I'm not familiar with that. But that could be a question I could ask Dr. White when the lecture, he gives his lectures. He seems to know a fair amount of history of these operations, so he might be able to answer that question better. So I'm gonna have to ask him that, see what he says. All right, so we're looking for wall motion abnormalities, because moving those coronary arteries could be problematic. There might be insufficient blood flow at times, will create ischemia and wall motion abnormalities. Okay, got to evaluate the pulmonary artery and the aorta. So the problem here is, we moved these vessels, but the valves stay where they are, which means pulmonic valve is facing high pressure. It's now the aortic valve. So it doesn't like that, so it's going to leak. So when I say here the neo-aortic regurgitation, the neo-aorta really has the pulmonic valve. When you think about it, why does the pulmonic valve leak and the aortic valve doesn't leak? Just because it's, this is bigger tissue? I don't know an answer for that. Because the aortic valve is really good at not leaking. Pulmonic valve stinks. So it makes you just wonder, I guess in the development, just the, in its higher pressures in the pulmonic valve, it's facing higher pressure, in the uterus, in the fetus, the fetus. Pulmonic valve is facing higher pressures during development, right? And then it gets lower pressures later on. So why is it just?
And they both have pretty negative consequences for their leaking. So it's not like the tricuspid valve where it's not too bad.
I mean, small amount of leakage, the right ventricle is fine. A lot of leakage, not so fine. So, but yeah, I don't know what story that is. All right. Now, sometimes we can do this kind of operation. So because there's some variability in the abnormality. So you see, this is with detransposition of the great arteries with a large VSD and significant pulmonic stenosis. So this is kind of like a tetralogy of Fallot situations, somewhat similar, because you got the VSD and the pulmonic, narrowing on the right side. So we're taking advantage of this situation where they can close the VSD, put in a patch, but they position that so they can baffle the blood flow from the left ventricle to the aorta. So you see going right in through here. So because of that defect, it allows them to kind of just direct it. Here's the little, it's kind of a patch / baffle where they direct the blood here from the LV to the aorta. Then they fix the pulmonic stenosis by here putting this valved conduit. So it's good to know what the Rastelli operation is. They could ask you that on a registry exam, because you would see that in an adult. So because you got this VSD present, normally in the detransposition of the great arteries, you don't necessarily have a VSD, although it's frequently do. If when you do have it, it's easier to then just direct this blood through the VSD from the left ventricle to the aorta. So they did that by putting in this VSD patch, and they just directed it in a way that's still allowing blood to go through it, but directing it to the aorta. And then they're fixing the pulmonic stenosis here with this conduit right there. So if you saw one of these, you have to just kind of assess it. You're assessing ventricular size and function, evaluating this conduit here, see if it's narrowed or leaking. You're interrogating this patch. Again, this is stuff you wouldn't be used to looking at, so this would probably require some telemedicine as well. Now, that's all detransposition, fixed detransposition. So you're gonna see the fixed people, not the people who haven't been fixed. You're gonna see the L transposition, you could see not fixed and fixed. All right, so with detransposition, you have normal looping of the ventricles. So that's the D, rightward looping. Now we've got leftward looping, L looping, which makes the ventricles switch. Notice the positioning of the aorta and pulmonary artery, similar to what we saw with detransposition. They're kind of side by side. They're not perpendicular to each other. So the aorta is anterior and to the left of the pulmonary artery. Okay. Normally, when you don't have transposition, the pulmonary artery is anterior and to the left. Right? When you see it on the screen, it's anterior and to the right, but that's the patient's left. So this is the same thing. We saw that with the detransposition, the aorta was anterior and to the left as well. Okay. So what's the problem here is we have switched the ventricles. Now we've still got deoxygenated blood coming in to the right side, okay, but it's the left ventricle over there because we switched the ventricles. The left ventricle is pumping to the pulmonary artery. So that means they got deoxygenated blood going to the lungs. That's good. Comes back into the left atrium. So notice the atria are where they're supposed to be. The ventricles are not. So the blood comes in the left atrium, goes into the right ventricle, and is pumped out to the aorta. So oxygenation, we're fine, but similar to what we saw with the repaired detransposition with the mustard and setting procedures, I still got a right ventricle pumping out to the aorta. So that's the problem. So these people, you can see these people as adults, but their right ventricle is not gonna be happy at some point. We gotta fix it eventually. You can see there's some other defects that can be associated with it. Okay, so again, oxygenation fine. Right ventricle will be unhappy. How are you gonna identify them? Yep. You're. What I was just stating was, how are we going to identify them? And you're asking the exact same question. So I hope you can wait 15 seconds. All right. Maybe less than 15 seconds, not time. How do you know the ventricles are switched? What clue do you have? And I guarantee you there'll be a test question on this. You can see there on the slide that maybe you can see on the slide there. Maybe it's just implied. All right. The valve goes with the ventricle, not with the atrium. The AV valve goes with the ventricle. Normally, which valve is superior to the other? You're talking about AV valve. The mitral valve is superior because the mitral valve thinks it's all that, and it's that superiority complex. Because the left side is better than the right side, right? Because pump to the brain thinks it's so great. That's how I remember it anyway. All right. So normally, you just see it's very subtle. With this, it's going to be a little less subtle. Okay, mitral valve is going to be a bit more superior. And so it's kind of like Epstein anomaly, where you get the tricuspid valve is like going way down, and you get increasing difference. It's just that, normally it's not gonna be that much, but you can see that's a bigger difference than you normally see. Normally it's just a little bit, just slightly superior. But when you see the valve is superior like that, you say, okay, that's the left side. And so I know that's the left ventricle, because the superior AV valve, that's gonna be mitral valve, it's gonna go with the ventricle goes with the valve, so I know that's the left ventricle. It's the right atrium over here. Here's my right ventricle, that's gonna be inferior. Also, I'll see a moderator band over there. So I'm gonna know. What's that? Well, I can't really see it too well, but if you move your transducer around, you'll be able to pick it up. So they're switched. That's gonna be your clue. Okay, inferior placed left AV valve. Well, it should be superior. So there's just switch. This one is supposed to be lower than that. The left. So this is the way we're saying this is left AV valve, but this is the left side. So left AV valve here is inferior, but it's really the tricuspid valve. On the left side, the wrong side. Inferiorly placed left AV valve, but it's really the tricuspid valve. Superior valve on the right, so that's the opposite of what it's supposed to be.
Is there a condition that'll give you an inferiorly placed mitral valve? So you see this,
Yes, you see this, All right, so the RV function is going to get bad. So that's a problem. The RV function is going to get bad.
Wait, so would it still have the pulmonary? Not the pulmonary?
Still have what?
Like everything else still be the same.
Yes, it's still going to oxygenate. It's going to be fine. Just we switch the ventricle. L looping. It looped the wrong way and switched the ventricles. That's it. Then there can be some other abnormalities. You see, there could be VSD, LVOT obstruction. So how do we fix it? Complicated. Double switch procedure. So we're doing that mustard procedure with arterial switch procedure. All right, so you see it's all combined. You gotta look at these things carefully here. So you see we got the systemic venous return. Where do we want it to go? We want it to go to the right side, which is over here. So we got to baffle it over there. And we want it to go to the pulmonary artery. So we had to switch the aorta and pulmonary arteries to do that. Okay, so pulmonary artery was over here, right? Left ventricle was pumping into pulmonary artery. So we moved it over here and switched the aorta over here, and you had to make the coronary arteries go with it. All right, so we're taking the systemic venous return, and we want it to go to the right ventricle, the right side of the heart, right? So it can go to the pulmonary circulation. So it's on the other side, so we got to baffle it over to go to the systemic venous atrium right over here. Okay, so we go, and then it goes in the right ventricle, and it needs to go to the pulmonary artery, but it was pumping to the aorta, so we had to switch the aorta and pulmonary artery. So you're gonna have two baffles in place, and the aorta and pulmonary artery are switched. Yep, the coronary arteries have to go to the aorta. So this is going to be, again, this is going to be the pulmonic valve coming over, is still here, right? Because this was pulmonary artery. Pulmonic valve stays in place, so that means that valve is probably going to leak. As we saw previously, going to leak more than aorta would leak.
This potentially cause issues with pulmonary hypotension.
Why would it cause pulmonary hypotension?
Getting deoxygenated blood to the lungs from the right ventricle.
But I mean, that normally gets deoxygenated blood goes into the lungs, and then it gets oxygenated.
I'm saying before the repair.
Before the repair, there was no trouble with oxygenation. Right, it's just your ventricles are switched, but you still had deoxygenated blood going through it. It's just that the two ventricles were just pumping to the wrong place, but the direction of the blood was going normally in terms of deoxygenated, systemic venous return going to the pulmonary circulation, pulmonary venous return, then ultimately going to the systemic circulation. That was still happening, just they're switching their jobs. And the positioning of the aorta and pulmonary artery were different. So it's quite a mess to then be monitoring those patients. So that would be something that would be, I would think, need some assistance. What would be interesting though, if this, since I don't know when they are doing this procedure. And who's doing the echoes on them? Like if they did this fairly early, they're doing the echoes in the pediatric lab. And then when they get older, that transition into who's doing the echoes would be interesting to know. Then you're gonna get these adult sonographers who have probably never seen these patients before, or so rarely that they're like, how do I do an echo to look at the baffles?
All out in the peds sonographer I mean, I feel like to get in peds, you have to master adult, right?
I mean, pediatric is harder than adult. And so I have